Hi, in this lecture, we are going to start looking at renal physiology. So how do the kidneys work? Think about the fact that 47 gallons of fluid enter your kidneys every single day. So the next time you grab a milk jug, right, a gallon of milk, look at that and imagine 47 of them, that would be the blood, going into your kidney. Well, clearly we don't eliminate that much as urine. So if 47 gallons comes in, which is about 180 liters, how much do we actually eliminate? What do we actually have as urine? It's only about 1% of that. So the kidneys are constantly having a tremendous amount of blood coming in, and then they're going to sort that blood and determine that only the waste products are going to leave and be eliminated as urine. Now, they do get 20 to 25% of your blood flow, as you mentioned earlier, because all that blood has to go to your kidneys for them to filter it. And they're critical for maintaining homeostasis. They control the volume of blood. They control where the water goes. Does the water leave as urine, or does it stay inside your blood to raise your blood volume? They determine the composition of blood. What's the electrolyte levels, calcium, the pH of blood? And then they excrete all the waste products that are produced daily. And we have a lot of nitrogenous waste just because we take in protein. And so they're giant filters. And when we look at renal physiology, there's three basic processes that have to happen. So the first thing is called filtration. And notice that filtration is going to happen up here. This whole structure was called a renal corpuscle. You have the glomerular capsule in yellow, that's the nephron part, and you have the glomerulus, that's the blood vessel part inside. And so filtration is when materials are going to leave your blood and they're going to enter the nephron. So the blood is filtered and molecules, material enters the nephron, and then once it's in the nephron, remember we're going to call it filtrate. So filtration's non-selective, just stuff goes. The second step of urine formation is called reabsorption. Now, reabsorption is moving things from the filtrate back into the blood. Because filtration is non-specific, it's like 10% just goes immediately from your blood. Doesn't matter if it's good or bad, you need it or not, it just goes and becomes filtrate. Now we need a way to pull back the good stuff. So that's reabsorption. And the last step for forming urine is called secretion. And secretion is moving materials from the blood back into the filtrate. So it's kind of like your body's last chance to get rid of anything it didn't want anymore. So an example I use a lot to describe this is, let's say you have like a big messy closet in your house and you're like, okay, that's it. I'm going to take care of this once and for all. So if you're really serious about cleaning it, the first thing you're going to do is just take everything out of it. And as you take everything out of it, that's filtration. Then you're going to look and you're going to choose, right? You're going to make piles and you might start pulling things back in that you know you want into that closet, or things you want to hold on to. That's reabsorption. You're choosing the good stuff. A lot of times when we do that, we start taking extra stuff that we really think we want. And then when we're looking at our closet, we're like, yeah, we don't really have room for that. So then you go and you pick the stuff that you're like, yeah, I can get rid of this. That's secretion. So it's kind of like this back and forth so that the kidneys make sure that what's leaving is the waste products and what's staying behind in your blood is what you need. So a couple terms to define first. Osmolarity refers to the osmotic pressure of a solution, and that's the amount of stuff in it. So the total number of solutes is the osmolarity. The higher the osmolarity, the more concentrated the solution is. The lower, the more dilute. And so we use these units called milliosmoles per liter. Most body fluids have an osmolarity of 300 milliosmoles per liter. So anything with that osmolarity, we would say is isotonic. Now, if we have a higher osmolarity, if we're saltier or have more solutes, that would be called hypertonic. And if the osmolarity is lower, remember that would be called hypotonic. When we measure things, we measure ions, we use units called milliequivalents per liter because ions have a charge. For example, calcium has 2 positive charges. Chloride has 1 negative charge. The units are called milliequivalents per liter. And whenever we measure organic molecules such as glucose, we usually use either milligrams per deciliter or grams per deciliter. So make sure you understand the appropriate units as we start talking about how these different molecules and how they move. So right now we're going to focus on filtration. And we know that filtration is passive. It does not require ATP to occur. It is driven by pressure though. It does require a hydrostatic pressure. And remember that hydrostatic pressure is directly proportional to your blood pressure. So if your blood pressure goes up, your hydrostatic pressure goes up, and vice versa. If we were to look inside the glomerulus, you might remember that the glomerulus has a much higher hydrostatic pressure than any other capillary in the body. It's around 50. Some books might say 55, so you might see 55 on old quizzes, but your book says 50. And we know it's higher because that diameter of the afferent arteriole was bigger than the diameter of the efferent, so blood comes in faster than it leaves, which causes the pressure to increase inside the glomerulus. We also know it's non-selective. So that means it's not choosy about what leaves. In fact, what determines if molecules leave is just their size. If they're small enough to get out of those fenestrated capillaries and these podocytes, they will enter your filtrate. So filtration is happening when materials from the blood are going to be moved into the nephron, forming the filtrate. So lots of things go: water, all kinds of ions, calcium, sodium, chloride, bicarb, glucose, amino acids, and even waste products. So a lot of stuff is actually filtered. And the estimate is that as the blood flows through, about 10% of it is filtered. And again, it's just 10% of it. So it has good stuff in there as well. So when we look at filtration, we have to look at the membrane. The filtration membrane is the barrier. It's the cells that are going to determine what can leave through filtration, since filtration is size dependent. So the membrane is literally the filter between the blood and in the glomerulus and the nephron in Bowman's capsule. So if we look at the membrane, we know the materials will pass from it into the capsule to form my filtrate, and we know it has 3 layers. The first layer are the fenestrated capillaries. Remember, the glomerulus has these pores or fenestrations, so it's pretty permeable. Now, those pores are not huge. Those pores actually help prevent the blood cells and the platelets. They don't get out of the capillary. Then we had the podocyte. This was the visceral layer. Remember, the visceral layers, they wrapped around. They had these little gaps between them called filtration slits. So these gaps are pretty small, and these keep most plasma proteins out. And these actually also prevent albumin from leaving. So albumin, you're not memorizing the numbers, but these slits are between maybe 6 to 7 nanometers thick, and albumin is like 7.1, 7.2. So usually albumin is just a little bit bigger and it can't fit through those slits. And then you have the basement membrane or the basal lamina of both basically, and that's going to keep the rest of the proteins out. It's kind of like a mesh, or think of it like a colander. So here's another view of it that might make it a little easier. We have our fenestrated capillaries. See the cells inside? They can't get out of those pores. We have our visceral layer of podocytes. Those little slits keep albumin in. And then you have the basal lamina, which is just where the two meet, and that's also going to help prevent any proteins from leaving. So we know filtration is non-selective. We know that it's just based on size, and that is driven by pressure. So we need to look at what causes filtration. So we have what's called an NFP, which is net filtration pressure. It's just the net force. So we're going to look at our pressures, and whichever one is dominant determines which way the materials go. So the first pressure we have is the glomerular hydrostatic pressure. So we have hydrostatic pressure in the glomerulus, and that is going to be pushing things out to favor filtration. And your book will use 50. Again, some previous books use 55, so just know you'll either see 50 or 55, no 50 for your test. And we already talked about it's high because that afferent arterial diameter is bigger than the efferent, so that accumulates. So that's favoring filtration. That's one of the main factors. Hydrostatic pressure is really dependent on blood pressure, and that's forcing material out. Well, it's opposed by the glomerular osmotic pressure. So remember, osmotic pressure of a capillary is pulling things back. It's the opposite of the hydrostatic pressure. So you might see different numbers depending on what book I used. Your book uses 30, so we're just going to go ahead and use 30. So that's dependent on the stuff in your blood. That's dependent on the osmolarity of the blood. So particularly, we know that albumin is one of the most abundant plasma proteins. It stays in the blood, and that's one of the main factors contributing to that pressure. Then we also have a capsule pressure. So Bowman's capsule, right? The glomerular capsule, there's fluid there. There's filtrate. So because there's fluid, there will be pressure, and that's going to be opposing filtration, and your book will use 10. Now, there's no osmotic pressure in the nephron. And the question is, why not? Well, there isn't one because there's no plasma proteins. Remember, they don't get through the filtration membrane. So therefore, we would just say the capsule osmotic pressure is 0. So if we're trying to look at how filtration occurs, we know we have a force of 50. We know we have the hydrostatic pressure of the glomerulus, right, pushing out. And then we know it's opposed by two pressures. You have the osmotic pressure of the capillary pulling back around 30, and then you have the capsule hydrostatic pressure, which is around 10. So we have a force, if we add these up together, of 40 opposing filtration, but we have a force of 50 encouraging, right, pushing filtration. So the difference is 10. So our NFP, our net filtration rate, is only 10 millimeters of mercury. That's enough to get 47 gallons or 180 liters of fluid into your kidneys every single day. That's the amount of filtrate that's going to be formed, and we need to maintain that number. Now, 10 is where it's supposed to be. Well, what if it changes? Well, what are some things that can change filtration? Well, what would either increase the NFP or what would decrease it? Well, we know that things that would increase the NFP could be anything that increases my glomerular hydrostatic pressure, right? Because if that 50 became 60, now my NFP becomes 20. Well, we know that that pressure is dependent on your blood pressure. So if my blood pressure were to go up or down, that could affect my glomerular hydrostatic pressure. It would affect it, and then that would change my filtration pressure. This NFP is critical for our kidneys to work. So they're very dependent on blood pressure. Another factor that could change this net filtration pressure is maybe my GHP stays the same, but what if my capillary osmotic pressure fell? What if that fell to 20? Well, if that was 20, now my opposition, right, is only 30. So now I'm still going to have a higher NFP. Well, we said that this osmotic pressure was really dependent on the stuff in my blood, particularly albumin. So if my albumin levels were to fall, that would therefore cause my osmotic pressure to also decrease, which would raise the net filtration pressure. We know albumin is made by the liver. So if I have any liver disease, I'm going to be concerned about my albumin levels and effects on my kidney. And the other organs that we look at for concerns with albumin are the kidneys. What if my filtration membrane has holes in it? So what if I have some damage here? And if I have damage, now my albumin, right, is going to leave my blood and enter my filtrate. So if I'm eliminating protein in my urine, particularly if I have albumin in my urine, that's a sign that there's kidney damage. And so if I have renal issues, I might urinate albumin and lose it that way, which will affect my net filtration pressure. So we always look at the kidneys and the liver. And so what we're really getting to is the number one thing as we go through kidney function is called the glomerular filtration rate, or GFR. This is the rate that the filtrate flows through the kidney. It has to go all the way through, right? The PCT, the loop, the DCT, and it has to be 125 mLs per minute. It's critical. If it's that rate, then everything's perfect. We have 180 liters per day. And as I mentioned, we say that about 10% enters every day. Well, what keeps that just right? What maintains our GFR so our kidneys are able to process all that blood? There's 3 factors. Number 1 is just the surface area. Do you have 2 kidneys or not? Now, we can live with 1 kidney, although our GFR will probably be a little less because you only have 1, but normally surface area doesn't change unless you have a disease. The permeability, same thing. That permeability membrane is pretty constant unless we have kidney disease. The thing that can change is the NFP. So the NFP has a little asterisk because it is the most important factor that maintains your GFR. Your net filtration pressure is directly proportional to GFR. So the net filtration pressure is 10. And as long as that's 10, then my GFR is going to be exactly where it's supposed to be at 125 mLs per minute. Well, it's directly proportional. So if my net filtration pressure decreases, so does my GFR. And if my net filtration pressure goes up, so does my GFR. So you can imagine that the body's going to be very concerned with maintaining that net filtration pressure and trying to make sure that any of these things don't cause a problem with it. And that's what we're going to look at in our next lecture when we look at how the body controls this GFR and NFP. So that's the end of today's lecture.